Atla? It's not moving. So good evening, everyone, and welcome to the panelists. So we have a surgeon, two hepatologists, and critical care anesthesia specialist for this session. So a 56 years male, blood group O positive, weight 71 kg with a BMI of 28 kg per meter square, diagnosed as CLD with decompensation as refractory ascites, encephalopathy, grade 2 varices, non-bleeder. So was evaluated for transplant. Etiology showed hereditary hemochromatosis. MELD sodium was 29 with a bili of 12, INR 3, sodium 139, and create of 0.8. So family had no blood group compatible donor. So we offered. So my first question would be, would you consider ABO-incompatible transplant for such a patient where MELD sodium is 29? So the question is open to everyone. I would like Dr. Abhishek Mathur, can you please comment on this question? Would you consider ABO-incompatible for a patient with MELD sodium of 29?
Yeah, so, my experience is, again, like I'm going to just preface it, I've been in the US for the last 20 years, so a MELD of 29 would probably get a deceased donor pretty quickly. So with that in mind, I think the point that Dr. Rella made is really important. I've probably only done one ACL or one ABO incompatible in the last 10 years, and it was an ACLF which was going down quickly. And so those are probably, those higher MELD patients might be the one which they're actually required.
Okay. So
to add up on this, with the blood group barrier, we essentially have only three options. Either keep waiting on a DDLT list or to go ahead with the ABO incompatible LDLT or for a liver paired exchange. Again, he's a blood group O positive who are disadvantaged for liver pair exchange. So there should be a shared decision making between the patients and the doctors.
So in this regard, so is there any cutoff for antibody titers beyond which ABO incompatible should not be offered to such sick patients? Dr. Chandan sir, can you please comment? Is there any cutoff for the MELD score, and is there any cutoff for antibody titers?
If it is ACLF high MELD, like how Dr. Sanjeev Sehgal said, more than 20, 22, 25, then better avoid ABO incompatible in ACLF. Secondly, if they have kidney injury, recent in sepsis episodes, then better avoid. And third, if titers are more than 500, better avoid.
Okay.
512.
So coming to this patient, we also follow a policy where we have a cutoff for titers. Coming to this patient, his IgG was 1:2048, which is way beyond our cutoff, and IgM 1:256. But there are a lot of centers which don't give much importance to pre-rituximab titers. So the donor was a son with a good graft GRWR of 0.8, LAI plus 14, and suitable for right lobe. CD1920 to start with were less than 1%. So next question would be, what kind of desensitization do you practice in your setup? Means, do you consider rituximab as an essential thing for everyone? If yes, what is the dose and how long do you wait?
Yeah, so this is the case of LDLT where we have some time to plan this surgery. So like we have discussed earlier, Dr. Sehgal has said, we give this rituximab 2 to 3 weeks before the transplant, and then we do the titers. If the titers are still high, then we do plasma exchange or immunoabsorption. And once the titers are in acceptable range, then we proceed with the transplant. Okay. And then post-transplant, again, we do a standard triple immunosuppression, but then we aim for a slightly higher TAC values of 10 to 12 nanogram per DL.
Okay. And what is the dose that you prefer to give? Is it a standard dose, or does it vary depending upon the thickness of the recipient?
Absolutely. So the house is divided about this dose of rituximab. Some say 200 mg per meter square, or some other people say 375. However, when the donor, the recipient is sick, like he's a high MELD or ACLF, in all such places we will tend to give slightly lower dose of rituximab.
Okay. Probably 100.
Okay. So basically, I think the purpose of rituximab here is to deplete the B cells, and once we achieve it through a low CD1920 percentage in the blood, I think the dose really doesn't matter. So we gave 200 mg to this patient considering his sick status. The 10 days after, so we follow a protocol where we give at least a gap of 2 weeks after rituximab. So we evaluate the titers after 10 days, and remaining 3 to 4 days when we start plex or other techniques to lower the titers. So the IgG was 1024, IgM 128, CD1920 was 0. So at this stage, what are the methods you practice to reduce antibody titers before going for transplant? So whether you prefer plex, whether you prefer immunoabsorption columns, or you decide depending upon the titers?
See, in this patient, usually plex is better than adsorption columns, but in this patient with titers of more than 1000, even after retux, after 2 weeks, better do adsorption columns, I think.
You know, I'll just make one point that all of this is the caveat is how the patient's doing, right? A MELD of 29 and a sick patient, you don't want to like drag it along and then you're dealing with other issues as you're going along. So you've got to figure out that balance of tolerating risk with ABO-Incompatible.
Okay. So just before this session, we had a talk on ABO-Incompatible where a question was asked whether there is a risk of infection is different between plex versus immunoabsorption column. So can anybody comment on that, whether means the number of sessions of plex required to bring down titers should be at least 3 to 4 with this titer 1024. So whether giving immunoabsorption in the first place itself is a good option?
No, actually, there is dearth of evidence in between plex and adsorption columns. But if you look at the titers, and as my panelist has said, it's about trying to reduce the titers in the shortest time possible. And usually these patients will have occult sepsis with high MELD, already given rituximab. So better do adsorption columns, reduce the titers quickly, and take up for surgery.
I have a different understanding about this thing. So this plex, in my opinion, is slightly non-selective one. And when you say immunoadsorption, that is slightly more selective for removal of anti-A or anti-B antibodies. So whenever a patient is septic or sick and the titers are high, I will like to go ahead with the immunoadsorption.
I think the cost also comes into play in this in a big way. So what is the target titer before you proceed for transplant? There are various centers which have different cutoffs of the titer.
Preferably less than 1:16.
1:16. Yeah. Does everybody agree on it, or there is a difference of opinion? Or anybody has an experience of doing it at 1:64 or 1:32 with good outcomes?
As low as possible, lesser than 16 maybe.
That is the desired thing, as low as possible. But many times we are unable to reach to that thing. So
It depends on how you communicate with the family, I think. That's
okay. So so this is the titers to start with 1024 and 128. So we did plex because of various logistic reasons, and so 5 sessions of plex, as you can see in the graph. The titers slowly they came down, and after the 5th session of plex, the lowest titer was 64. IgG was 1:64 and IgM was 1:2. So would you consider transplanting at this titer level on 9th of Jan when the titers were at the lowest possible? And
yeah, I think so, because it's a high MELD patient, so better proceed.
okay. And any difference of opinion from anyone?
Initially began with the high titers to begin with, and he was a high melder ACLF. We should reconsider at this stage about going ahead with the transplant this way.
Yeah, so we had a similar plan. So on 9th, after the plex, the titer were 1:64:2. As a policy, we do send titers on the early morning before doing transplants. On 10th morning, the titers are rebounded to 1:256 and 1:4, which was strictly against what we think is a good option to go ahead. So what could be the reason for rebound titers or refractory titers? So these are actually 2 questions. What would be the reason where the titers are not coming down in spite of repeated plex or immunoabsorption? And once they come down, what could be the potential reason for going up again?
I think we started with the high titers and we gave 200 mg of rituximab because of the high MELD status. I think we should hit harder at the first place. When we don't, we are a little conservative with rituximab, then this happens and we are wondering why the titers are not coming down. Because all other things are temporary. Plex will only remove whatever antibodies are there in the plasma or serum.
Yeah, but the B cell depletion was adequate as per the CD1920. So again, is CD1920 a good representation of B cell depletion, or are there other sources of B cell which can say put cells in B cells into the stream after transplant? Are there other sources of other lymphoid organs?
Maybe the patient has received products before the transplant or before we contemplated transplant on some other center. So that can be a reason. Or he's actually from baseline is immunologically active with the high titers. So that's a
So how many of you would prefer to give a repeat dose of rituximab?
I think it's better to give in this patient repeat.
So, and coming to this question again, if there is a chance of giving a repeat dose of rituximab, would giving a higher dose of rituximab in the first place itself is a better option?
I think you give 200 mg is a good dose actually. For the high meld 200 mg is a good.
The house itself is open for any questions
Can I
right now. So, and how many of would you prefer bortezomib when the titers are not coming down or basically rebounded after coming down? Any experience with bortezomib?
Pre-transplant high meld bortezomib, I am very scared. Maybe post
There are good reasons to be scared. I will come up. So we actually gave bortezomib, as you can see from the graph, on 2 days after stopping plex, and patient tolerated it well, and all infective workup was negative before we gave bortezomib in form of cultures and procal. And we repeated a second dose. Our plan was to give 3 doses. We repeated a second dose. Unfortunately, after 14th patient developed severe sepsis. So coming to the plex, Dr. Vijay, what is the replacement fluid of choice in plex when done for reducing titer? Is it the same when you do it for other causes like ALF, or does the choice of fluid have any role in depleting the titers? The choice of fluid that we have is albumin versus FFP.
Yeah, so we don't fully replace the FFP, right? We exchange to 1:1 to 1.5 times the plasma is what we generally replace during the plex. So we don't fully replace the FFP because we don't want to do a fluid overload. We do give albumin along with FFP. That will be the safer choice.
Okay, and another question, like when doing plex, there is, what do you prefer? A combination of like 60-40 or 80-20 of albumin FFP, or plain albumin plasmapheresis and transfusing FFP over and above it separately?
The experience for me is usually FFP with albumin is what we generally use.
Okay. Always in the this plex thing, the most of the volume is with FFPs only. If at all we have to use albumin, like in ACLF status, when the albumin can be dysfunctional, in that case we can use up to 20% of volume with albumin, but it should never exceed 30% of volume. Whether this giving only FFP has any role in sensitization, that needs to be checked.
Generally, the FFP used is AB positive. Generally, that what is used in ABO-Incompatible. Okay. So again, the take-home message is open-ended. Can we consider that ABO-Incompatible liver transplant should be offered or can be offered to sick recipients only if the antibody titers are low? Can we make a statement like that? ABO-Incompatible transplant for sick recipients or for ACLF, can it be done only if the starting titers are low? Should we have a cutoff?
I think that first point is very valid. Okay. If it is low,
I can remove the query mark from there.
Yeah, definitely.
Okay. So, and
you can have a survey actually.
Yes. There is a lot of debate in ABO-Incompatible. Different centers have different protocols. And failure to reduce titers or rebound in titers, should it be considered as a contraindication for liver transplant? As an absolute
that's very valid.
contraindication?
Yeah.
Okay. So, any questions from the audience?
I just wanted to make a couple of comments about this case. Thanks, Raj. We wanted to discuss this case because there were so many things which we felt were not what we normally see in the setting of ABO-Incompatible transplant. Yeah, he was a sick patient. In an ideal world, he should get an early cadaveric transplantation. It doesn't have ABO-Incompatible donor. That's what we need. But unfortunately, we don't live in an ideal world, and this was the only option. The donor looked good. The interesting things were the titers were high, but the CD19 and 20 count even before in desensitization was 0%. So there was actually no, on paper, there were no B cells in this patient at all. So that's the reason why we felt that if we give some desensitization and quickly bring the titers down with plasma exchange, we should be able to do a safe ABO. That was the thinking behind giving the low dose and then doing the plasma exchange. Now, to our surprise, the rebound was much more than what we normally see. Normally, what happens, we do plasma, it comes down to 16. Next day morning, it will be 32 or maybe 64. This was from, then went to 256, it actually went up to 1,000. And that's when we just didn't understand what is happening. There are no B cells both before and after rituximab, but having titers jumping like never seen before. That's when I spoke to Abhijit. And then we got
CD138.
We did the plasma cell counts, and we found that the plasma cell counts were actually very high compared to. So this patient actually had a lot of plasma cells, very little B cells, and unfortunately rituximab doesn't work on plasma cells. It only works on B cells. And we felt that maybe this is the source for this relapsing titers, and that was the point we decided to give bortezomib, because we thought, okay, these are the plasma cells which are actually causing this rebound. Maybe if we deal with these plasma cells, hopefully the titers will start coming down. Unfortunately, we could never get to the point where we could bring the titers down. So so this was we've done over 60 ABO-incompatible transplants, but we never had a challenge like this before. And I felt that this is something that we discussed, because first of all, no B cells before itself, and a huge rebound, and a large plasma cell pool which could have caused the rebound. And like I said, like the panel said, I think high titers or rebound titers, probably it is not a good idea to do a transplant. Thank you.
Would doing the plasma cell marker and giving bortezomib in the initial phase make a difference?
No. So what happens is, when you give rituximab, most of the centers, what they do is they check CD19 baseline. You should start checking CD38 or 138, whatever is available as well, because in the cycle of maturity of cells from pre-B to B to plasma cells, when you are giving rituximab, at that time there might be some transition which is happening from B to plasma cells. So some of the cells which have CD20 expression, you block those cells, but the cells which has already matured towards plasma cells, they are left unattacked, and these are the ones which are the responsible factors for rebound antibodies, and where the role of bortezomib comes. Now, whatever I've seen in last 10 years in ABO-incompatible is, the worst possible thing is rebound. You can start with a higher titer, but if once you do a plasmapheresis, never say that, okay, I have reached a titer of 16, tomorrow I'm going to do the transplant. We have stopped doing transplants next day after the plasmapheresis. We give at least 24 hours of cooling period to see if the rebound is happening. Those are the worst performing patients. If you're seeing rebound, don't go forward. Look at all these things. If you have to add bortezomib, there was a question about pre-bortezomib. It works well when you see these CD38 positivity, and you can even look at comparing the percentage and absolute number of cells. If it is increasing, then definitely there are B cells, and that is going to cause trouble. And these are the patients, you'll 100% have biliary problems in the coming times if you do these transplants. So bortezomib, 3 to 4 doses, that's what we normally do if we see this CD38 positivity and a rebound happening. And even after bortezomib, the rebound still happens. These are the patients we should exclude, because whatever we are doing, it is like kind of doing a medical splenectomy. The lymph nodes are still creating, working, and it is not working in favor of ABO-incompatible transplant.
There is some literature which says that the rituximab will work only on the circulating B cells, and the secondary lymphoid organs can be a source of rebound in titers. How practical is that? Can the second dose, repeat dose of rituximab target that?
So there is a paper by Professor Igawa which talks about it. Repeated dosing are actually more dangerous than a high single dose. So if you have to do it, it's better to give a higher single dose rather than doing a repeated dosing.
Okay. Thank you. Thank you, sir.
We actually did a case with very low titers to start with, which was only 1:8. Even post-transplant also, the titers were always 1:8, and we started triple immunosuppression immediately after transplant. But on day 6 post-transplant, the patient started developing severe rejection. We then supplemented with IVIG, second dose of rituximab, and we started plasmapheresis. But unfortunately, the patient developed secondary sepsis and severe CMV viremia, because of which we could not venture bortezomib in that case. So I would like to say that even though the titers were only 1:8 post-transplant, even then there's a chance of him going into very severe rejection post-operatively.
So, I mean, one thing that we should keep in mind is we are doing ABO-incompatible transplant. That does not mean all the rejections are because of those antibodies. I mean, the patient can have a ACR, like compatible transplant as well. So it is not that if you're doing ABO-incompatible transplant, you just have to think about antibody-mediated rejection. And antibody-mediated rejection in ABO-incompatible is also different from ABO-compatible transplant as well. So we have to keep all those things in mind while doing that. And thing about plasmapheresis, if we are doing conventional plasmapheresis, I mean, my thought is we should use only plasma and avoid albumin in that situation. And personally, I would want to avoid albumin whenever we are preparing a patient for ABO-incompatible, because we are not checking the antibody titers in the albumin levels, so in the albumin which we are giving. So it's better to use a AB plasma in the entire scenario.
Sumna has a question.
When we have this rebound titers, rise in titers, the thought process should also be to look at infections at this point of time, because that itself can precipitate rebound of these titers. What is your take on that?
So the infections
like say your titers are coming down and again it keeps rising. At that point, would you really look at if there is infection which is actually precipitating these things, or
means generally the patient was checked for these infections, because at that point we decided to give botulinum. So that was the time when we sent cultures and procal, and everything was negative for that case. But we have seen cases where the rebound happens, or I should not say rebound, the titers are found increased in cases of sepsis as well, but it is never so marked. It may be 1 log or 2 log, never like 3 logs or 4 logs. What we saw in this case was almost 4 logs increase from 64 to 256. So I don't think the infection is so significant to cause such a rebound. It would be very apparent from the clinical setting itself.
No, I mean, again, it's not written anywhere, but I feel that when there is a rebound of titers, there may be some subtle thing going on which is not evident on your cultures, or it can be a viral infection which can precipitate these rebound titers. I think that's a thought that should go into our minds
the
when it's happening.
infections can actually mask the rejection. I mean, it can actually coincide with the rejection episode. So high spikes of fever can actually be mistaken to be sepsis along with an ongoing AMR.
Especially when we are talking about these ACLFs with a bilirubin of 29.